Hello, everyone out there. Hello, all of you. Great to see a packed house tonight. I'm Josh Macauer. I'm a professor of medicine and bioengineering here at Stanford University and founder and director of Biodesign. I'm glad I had to look at my notes to know, to read that. So tells you where my head's at right now. No, this is the second Innovators Workbench of sort of this season. And it's a really special one because it's actually, and what I'm hoping is it's actually a story that all of you can relate to, because Chris was actually a student here. Chris Mansi is a neurosurgeon. He trained and practiced in the UK, and he came here as an MBA at Stanford. And I think it was back 2015, right?
Yeah.
Took the biodesign innovation class. And so he's one, we're proud to see our graduates do so well. So it's just an honor to have him here. And he co-founded this amazing company that really, I think, may be the very first AI healthcare company ever, in fact, which is pretty amazing, and has had to pioneer so many and break down so many barriers along the way. And I think he'll be talking about that. What's cool is that at this point, this technology is distributed in 1,500 hospitals, and it touches over 45,000 healthcare providers nationwide. And I think you said a patient every 10 seconds, right? Amazing. I think that deserves a round of applause right there. I mean, that is incredible. We talk about the impact that innovation can have. It's an ability to save lives, and that's what we're going to hear about tonight. So there's no question why this is a packed house today. So interviewing Chris will be Michelle de Haaff. So Michelle is an assistant director of digital health here. She teaches two courses with us. One is called Biodesign for Digital Health, and also another one for Biodesign and Entrepreneurship for Societal Health. And she's been working with us for many years. She is a senior leader with us, and she's played senior leadership roles in multiple digital health companies. So the perfect person to understand and be able to help us tell Chris's story tonight. So tonight's also a special night because every academic season, we always have one night that is really dedicated to the memory of Tracy Lefteroff. And this event is sponsored by Wilson Sonsini Goodrich Rosati and the Fogarty Innovation Group. And so that allows me to now introduce Andrew, the CEO of Fogarty Innovation, to share a few words about Tracy.
So thanks, Josh. We're honored, very, very honored, I should say, to co-host tonight. As Josh just said, this presentation from the Innovators Workbench is named in memory of Tracy Lefteroff, who passed away around a decade ago. Tracy was a giant in our industry, and many of you had the privilege of working with him. But for those who didn't get that chance, I just want to say a quick few words about him. Tracy played a seminal role in the development of our industry. I'd even go as far to call him a co-founder of our industry. He rose to become the global managing partner of private equity and venture capital at PwC. Easy than saying the whole thing. Tracy was known for his remarkably insightful business advice and counsel. And I do say business advice, not just accounting. He was so much more. He counseled many folks who were and went on to become leaders in our industry. He was a quintessential connector of people, both at the professional and the personal level. I was lucky enough to have the opportunity to spend time with Tracy in my first CEO role, meeting often at his table at Ilfanayo in Palo Alto. He was gracious, generous with his time, and thoughtful in his advice. For someone who had achieved so much in his career, he remained remarkably grounded. In recognition of his impact and in his memory, we, along with the Lefteroff Advisory Committee, host an annual internship program where college students from around the world, it used to be around the country, but now from around the world, spend a summer living the MedTech startup experience. In addition, we have the privilege of co-hosting tonight's event. So welcome to tonight's show. I'm very much looking forward to this. It's good to see another, well, I was going to Englishman, it's okay.
Yeah.
Coming from an Australian, but really looking forward to hearing our extraordinary guest speaker introducing us to what, as Josh just pointed out, a breakthrough company. So good luck. Have fun.
Thank you.
Thank you very much. Thanks, Andrew. Again, thank you, Fogarty Innovation and Wilson Sonsini Goodrich Rosati. A few notes. Please silence your phones. Appreciate that. And a special thank you to Deja Hill and Antia Kirchner for helping set this up tonight. Thank you all. And now, yes, one more announcement, which is right after this, we'll have a very short, nice little reception just outside the courtyard. So I hope you can join us for that. And without further ado, Michelle, take it away. Thank you.
Thank you, everybody, for being here. Thank you, Chris. We're so excited to have you here. And we are going to talk about this market, $175 billion AI in healthcare market projected in 2029. And we're going to talk about the rocket ship of AI in healthcare. But the neat thing about the Innovators Workbench is we also get the backstory, because we all want to know how you got here. And so we're going to kind of roll it back a little bit to get your story. And I know there's many innovators in the room, many aspiring innovators in the room. So we all want to kind of hear how you ended up here. So I'm going to go really far back and start, like, what sparked your interest in medicine in the early days?
Well, first of all, thank you very much for having me, and thanks everyone for coming today. So I grew up in the north of England, a place called Newcastle. I had an immigrant father who's Egyptian Sudanese and a mum who's from Newcastle. And my grandmother always said that the job that was the best possible job on the planet was being the local PCP or GP. And where I grew up, there wasn't venture capital. There wasn't. My mum was a computer scientist, but was doing very different types of computer science than was happening over here in this part of the world. You know, there wasn't private equity. There were lawyers, but there weren't many jobs out there that you would look up and aspire to. But being a doctor was one of them. I loved science and was influenced by my grandmother say, "Hey, this sounds like a really good way to do what you like, science, and also to do something good for people." So applied for med school, went to Cambridge, did med school there, and really fell in love with the brain, with neuroscience. In my different system in the UK, right, you do, instead of doing your degree and then going to med school, you do it from age 18, but you still do a degree. And mine was in cognitive neuroscience and experimental psychology. So I was doing a lot of the early, fast and slow thinking tests. But instead of, we're basically replicating tests that had been done on rats and pigeons, but on Cambridge med students. It turns out the results were the same. And I just really fell in love with neuroscience and, the idea of understanding this amazing thing up here that we clearly don't understand today, and thought I was going to be a neurologist. And that's where I was heading. But in my neurology placements, I kept on getting drawn to the OR, where you could do things. I love the study of neuroscience, but I also wanted to be action oriented. And so ended up going into neurosurgery.
Okay, so amazing. You're in neurosurgery, you're in the NIH practicing. And then you kind of said, I want to go into healthcare, tech, I want to go into business. What kind of prompted you to make a switch and come out west to the United States and study at Stanford?
So I started a couple of medical and surgical education companies during residency, basically because just like here, you get paid no money, and my residency was in London, so I was broke. And so while my friends from McKinsey that I live with and from JP Morgan were going out, partying, I had no money for that. So I started a company instead. And I got the bug for it. I just learned a lot. The first company, I think we we made $10,000. That was it in a year. Profitably though, apart from my own time, obviously. But I learned how to build a website. I learned how to empathize with potential buyers. And kind of what business was, and that gave me the bug. Started another company which was a lot more successful, and we struggled to get that away outside of the UK. We were trying to get it into India because it's a platform that should work there as well. We wanted to try and tackle that TAM. but didn't really have any of the business chops to do that. And a friend, the guy I was living with, said, "Hey, have you thought about doing an MBA?" And I said, "What's an MBA? Never heard of it." Most doctors in the British NHS, they go off and do PhDs versus an MBA. But I was reading a lot of the literature, the books coming out of Silicon Valley at the time. This is 2011. So the Paul Graham blogs from Y Combinator, the Lean Startup. And I thought that's amazing that this ecosystem where you can go out and you can test your ideas and you get lots of support. That sounds great. So I applied to Stanford, luckily got into the GSB. I came here thinking I would learn a lot and take it back to the NHS. But it's interesting thinking back, like week one, day one of business school, I was over in the D school, like doing classes on entrepreneurship combined with science, and then immediately did biodesign. So I was already clearly like moving towards doing more company building. And I just realized that in this ecosystem, when you've got so many great entrepreneurs around you, so many great computer scientists, there's an opportunity to build something really big. And so I ended up starting the company and leaving neurosurgery.
Okay. All right. So then share with us the roots of Viz.ai. How did you get started? Where did you get started?
Yeah, I think now it's kind of obvious that, AI is having a huge impact and will have an even bigger impact on healthcare. They'll just like the internet, there's going to be the pre-AI and the post-AI world of healthcare. But back then it was not as obvious. And really, we were just looking to solve a problem. So we did biodesign. And my project wasn't in my field. I think it's very smart that you're made to do something outside of your own field. I did a project on deep vein thromboses, which I wasn't interested in at the time, but I really loved the learning. I really loved the forcing you outside of your zone of interest. So you're just really trying to you really get uncomfortable because you don't know how the workflow, how the treatment works for this other disease. And I suddenly realized that in my own work, and there were many stories like this, I think every clinician will have them, you'll treat a patient and the outcome won't be as good as it should have been. And some of it's down to what you do, but a lot of it's down to what happened before that patient got to you, the messy world of workflow. That can mean it takes many, many hours, right, for those emergency patients to get to you. And biodesign taught me to really focus on what the real need is instead of what I was seeing in front of me in the OR. And I realized when the thrombectomy trials, which I think most of you will have heard of in 2015 when they came out, that there was amazing treatment for the most devastating disease, the number one cause of lifelong disability, a stroke. There's an amazing treatment for it, but patients were never going to get to that treatment on time unless there was something that could trigger and organize the workflow. Stanford, amazing hospital, but there's neuroradiologists, there's neurologists, there's neurosurgeons, everybody on staff. That's not the way healthcare happens in almost every other setting. And so me and my team in the early days went out and we're traveling around in a cab, around the rural areas of North Carolina, Tennessee, and Georgia, where all of these strokes were happening. And we were hearing, one center where they're real experts, they're treating more patients than anyone else in the country, and they know everything about it. They run the trials. And then 2 miles down the road, they've never heard of the treatment. They've never heard of the particular disease, which is a large vessel occlusion stroke. As we realized it was a big opportunity. If you could use AI to detect those patients in the more non-specialist setting, but let the specialist know, that patient would have a chance of the expertise of that specialist who likes the disease, wants more of those patients, wants to be able to help those patients, could drive the workflow and could get them to their hospital, who then benefits financially from having those patients there. So we suddenly realized that this innovation of the time AI was all about deep learning back in 2014, 2015, 2016, an inflection point in technology, just like you see today with foundational models. But that was you can now tell the difference between a cat and a dog. You can also tell the difference between a stroke and not a stroke, or a certain type of stroke, another type of stroke. Using that simple innovation, you could maybe trigger a whole new workflow that would allow those specialists to pull those patients into their realm of expertise, reducing time to treatment, increasing treatment rates, and improving outcomes. And so we went from the early days of probably playing with the technology, thinking, oh, this is really fun and cool, to going, hey, we've got a real way to help patients here, and there's a business model behind it.
Yeah. So you recognize this unmet need in the stroke area, probably saw that it maybe was extensible to other areas. You went from the idea and the unmet need. What challenges did you face then, kind of transitioning that into an actual company?
Yeah, so those of you who started companies will know this, and those of you who are thinking of starting companies need to know this. Every 3 to 6 months is a new hurdle, a new challenge you have to overcome, and it never stops, right? If you talk to, Jensen Huang, the CEO of NVIDIA, he'll say exactly the same, right? There's always something you've got to overcome that's taking your attention. So in those early days, we first of all identified the right innovators to work with, because I was a neurosurgeon, but I hadn't treated much stroke, because stroke was a new disease that they were treating. I wasn't treating it every day. I don't know the subtleties, the intricacies of what needs to happen. So you have to find those innovators to work with. So we identified those, and 2 hospitals were our first 2 hospitals. One was in Chattanooga, Tennessee, which I'm sure not many Australians have been to, but certainly not many Brits have been to. And then Grady in Atlanta. So identify those innovators. They knew exactly what problem needed to be solved. And when they saw a technology, they immediately were like, oh my God, this is amazing. Can we have it? We can do this, that, and this with it. But then you have to take it through the FDA. And obviously the FDA had not had any predicates. There was no easy pathway to follow. I pulled out my Biodesign book. I was like, oh, fantastic, 510K, this will be, this many months. We go to the FDA, do a pre-sub, and just get destroyed. And what really happens, they send you the destruction in an email, a 6-page long email 3 days before, and then you've got to get your team, which is obviously small at the time, together to try and work out how to respond. And we thought maybe the company was over at that stage. We thought, hey, we're not going to get FDA clearance there. What we thought could be a predicate, they're just basically saying no to, and there's all these issues. But we went to DC. Most of them are virtual now, I think. But then you always used to go. It was pre-COVID. You used to always go to DC. And what we were very successfully able to do was build a relationship with the FDA by explaining to them the need for the patient, the American population. We had a neurointerventionist with us. And within 5 minutes, it turned around. The medical expert, who was a radiologist, who never treated stroke in their life, immediately was like, oh, I got this wrong. I thought you were talking about hemorrhage, not ischemic stroke. Oh, okay, I wasn't aware of thrombectomy. Okay, that makes sense. Now let's start again. And they basically very strongly hinted to us, you won't be able to do a 510K, go down the de novo route, which I remember hearing, but I know that's a really hard route to go down. But ultimately with the FDA, once they understand the benefit for patients, they really do try and help you get your innovation through. And 4 months later, we had clearance.
Wow, that's incredible.
Yeah.
Okay, so we haven't talked much about what Viz.ai does. Could you kind of explain, how does the product work? What does it do?
Yeah, so I'll use stroke as an example, maybe give a more chronic disease example, because we work across the 16 live disease areas or therapeutic areas, and many more coming. But every single one has exactly the same type of system. So you all know the EMR, the EHR. We think of that as a parallel system to us. That's a system of record where people write in their notes, billing happens, storage happens. Viz is more of a system of action. What we're trying to do is help doctors take the next best clinical action. And we're really focused on the specialists who are experts in diagnosis and treatment of disease, right? If you're a neurovascular surgeon, you know how to read a brain scan, you know what to do with that patient. If you're an ED physician, it's probably much better now, but at the time, no ED physician could really, unless they took a specialist interest, read a CT angiogram, which is the diagnosis, or a CT perfusion scan. So they'd have to wait for that scan to go into the radiologist's work queue. Often at the time, the radiologist would need to consult a neuroradiology colleague. If you're in one of those more peripheral spoke hospitals, that would be in another hospital, so that would take some time, or might be a teleradiology service. Then they tell the ED physician about a patient's having a stroke, and then the ED physician would try and get hold of the neurologist and neurosurgeon. All of that took a long time. We know from the Stratus registry that the median time to treatment was between 3 hours if you were in the comprehensive stroke center already, and 5 hours if you're in a spoke hospital. And all that time, every minute, 2 million brain cells are dying. So the system wasn't working. What Viz did instead was, as soon as that scan was done, within minutes, it would go up to us in the cloud, and within minutes, the algorithm would have read the scan and immediately alert all of those people. So the neurologist, the neurointerventionist, the ED physician, the radiologist, who could then very quickly decide, yes, this is the right course of treatment. Yes, this patient needs a thrombectomy. Hey, we should consider TPA, or actually, no, this patient is not having a stroke, they're having something else, whatever it is. But all of that would happen within minutes via the mobile phone. So we would send that alert to these doctors' mobile phones. They would look at it, they'd be able to communicate and collaborate and decide on care. And that's the model that we have really for every single disease. So even for chronic disease, think of anything oncological or something like a rare cardiology disease like cardiomyopathy. Cardiomyopathy is a good example because we just got another de novo for the first AI on ECG as a trigger. What that does is it doesn't just alert the local PCP who's done ECG or cardiologist. It's ingesting ECGs no matter what the cause of the ECG. And if it finds HCM, it's telling the one HCM specialist in the health system who might be interested in this patient, hey, there's a suspected HCM, take a look. And again, that specialist knows exactly what to do for that patient. Everyone else does not. And so we enable them to know about more patients and allow them to take the next best clinical action. And that's interesting. That's taken the median diagnosis down from 5 years down to 5 weeks. So it's not, 5 hours down to 5 minutes, but it's still a huge, huge difference for that patient, huge difference for the outcome because there's now a good treatment for this disease, and then also for the health system who gets more of those patients in.
So what you describe actually changes the workflow in a lot of these hospitals. And if you've sold into providers, like many of us have, you know that they're pretty much allergic to any big changes, especially changes in workflows that they've had for years. Did you face that issue? How did you handle it if you did?
Yeah, we are a workflow company. Yes, we do AI and imaging, but we are a workflow company. And workflow, I think, is everything in healthcare. Because even for those of you who are starting device companies or drug companies, your device or drug will only be used if a qualified physician who knows about the disease gets hold of that patient, which doesn't happen. Well, I think the statistics for new disease, it's single percentage digits that it actually happens. So we decided very early on, it's all about the workflow. And actually, slight tangent, that happened because when I was in Biodesign, my wife was at CERC. Have any of you from CERC, the Clinical Excellence Research Center? And because of that, I happened to bring the Biodesign fellows in class together with CERC. And we used to have these conversations about this. And CERC is all about how do you implementation science. Okay, you've got cool technology, but how do you actually implement it in a population? So right from the start, we realized that throwing technology at healthcare and hoping for it to stick would fail. Like technological determinism, it just does not work. And so we go in, we have a whole team of humans, of nurses, specialists for each disease, who have worked at the centers that are doing this well. And so have worked out a bunch of the kinks, whether it's clinical workflow, prior auth, administrative workflow, all of the reasons why things fall down the cracks. We'll hire that team and they will go in and they will actually do change management together with the software. And then the software's job is really easy. It's just to keep that easy workflow now sticky. And we see that, right? But we failed a lot in the early days in places where we didn't do that. There's one place at University of Utah, which has now got one of our best performing centers, but it just wasn't working for some reason. And what had happened was the sales lead had gone in, very good salesperson, gone in and sold the neurosurgeon, but had forgotten to include the neurologist, teleneurologist, the radiologist, and everyone else, as they weren't using the product. And so all of a sudden, this software, which had so much potential, was hated by the team and failed. We went in, we had our clinical success team go in, work with the neurologist, with the angiotechs, and all of a sudden they saw the value to them. And now that workflow became so much easier than it was before. So I actually take the opposite approach. I think if you want to change outcomes, the goal of technology is to change that workflow for the better. And so that's really where we focus.
So it sounds like you kind of require a big team to go in, big sales push to go in and sell this. In those early days, did they get it? Did they immediately get it, the customer? Or, how long did it take to really kind of get through to those early customers?
Yeah, it was surprisingly easy, because what we'd done is we'd gone to the Innovator clinicians who essentially took the very basic version of what we had and said, we love this, but you need this, 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 and that, right? So, in the early days, we didn't know how to deliver the insights, and it became very obvious from working with those hospitals in the South that they didn't want it delivered in the EHR. They wanted it delivered on their mobile phones because they're running around the hospital having a busy job. So once we'd gone through that stage, we then had a product that we could put in the hands of clinicians, and they would go, yes, we want this. And it was so easy to show. You could try and explain it to them. You could try and talk about the value, and that would take forever. Or you could show them the product, and they were like, yes, I want this. So they could feel it, they could use it. We put a demo on the App Store so everyone could download. I used to spend a lot of time just sending that demo around to doctors who, again, would try it and go, yeah, I want this. But then there's the whole administrative sale, right? So you've sold the clinician. That's great. You've got a champion. But there's an administrator at that time would have been the VP of neurology or neuroscience or neurovascular, depending. And they have an Excel spreadsheet that you have to get budget from. And so then it's about the ROI sale. Like, how do you convince them that this thing that the clinician wants is actually going to be beneficial to them? And they absolutely care about patients, but they also have a job to make sure that their department is functioning financially. So there we had to build the financial argument. And in stroke, what we had was this dual value prop of clear clinical value. Patients got treated an hour faster, meaning, 120 million brain cells were saved. And then that translated, we knew through clinical trials, to about a year of reduced disability. So really big deal there. But it also meant that more patients got thrombectomies, which is a surgical procedure. And in the US, the surgical procedure gets paid more than a medical procedure. So we'd switch people from a medical DRG to a surgical DRG and essentially take a loss-making patient who becomes very disabled into a profit-making, a very highly profit-making patient who's not as disabled, or ideally not disabled at all. And so you have the clinical and financial value prop for that administrator, and those two allowed us to sell from the innovators to the early adopters. And then once you've done that, you've got to cross the chasm, right? You've got to now go to the main market who might want a little bit more. And that was about, first of all, having all of those key opinion leaders talking in conferences about the clinical value, the financial value, but also publishing papers and all the rest of it. So we were able to do this well, I think, by focusing on people who are saying yes and not worrying if people are saying no. Because for our early product, if someone didn't have a neurointerventional program, it doesn't matter if Viz is there or not, we're not going to help more patients. And so we had to go the places that were ready to adopt. Luckily, those are the doctors who are going to conferences, who are looking to innovate anyway. So we were able to find those people reasonably easily.
So this sounds like a real surround sound kind of sale. What competencies were you looking for when you hired a sales team?
Well, I could probably give you a good answer now. Back then, I was clueless, right? So I was the main salesperson. I could sell it. I could definitely sell. It was very easy for me to sell the clinical value prop. And then I learned pretty quickly to sell the financial value prop, but that's not it, right? You then need to bird dog it through all of, IT and all the rest of it. So we tried a radiology salesperson. He was a very good radiology salesperson, but he didn't know the clinical side of it at all, so he failed. And then we pulled someone over actually from Medtronic who had so many relations. Medtronic strike a penumbra basically, but Medtronic, at the time at least, was the leader in neurovascular and had we sold the most devices, had sponsored all the trials. And so we pulled someone over who was credible, really knew all these people, knew the disease really well, didn't actually know software at all, but we were able to complement him with our implementation team, et cetera, to get it through. And so the combination of the two of us were able to sell it through. And at that time, it wasn't surround sound. It was more just, multi-stakeholder. Now it's surround sound. Now we have 16 different diseases. So you have to sell into cardiology and vascular and oncology. You have to sell in the acute setting and the chronic setting. And so now brand really matters. And so the marketing side of it, appearing at conferences, having papers, we're just named as one of Fast Company's most innovative companies. Really, those things really matter, right? Because people see it on LinkedIn and Twitter, they go, "Oh, this is cool. I want to maybe, I want to maybe have this in my hospital too." So the surround sound actually has come a little bit later when it's a true enterprise sale versus a departmental sale.
Yeah. Okay. You were one of the first to get, if not the first, to get reimbursed.
Yeah.
Yeah. Explain your your journey with CMS and how you actually achieve that.
Yeah. So I think we're the first, and I think still to this day, the only AI software that's got it that hasn't got breakthrough. There's a company after us called Caption Health, really nice company that does ultrasound cardiology AI, but they got it because they had breakthrough designation. I think we maybe got our clearance before breakthrough, or for whatever reason, we were not a breakthrough. So we had to prove three things to CMS. We had to prove that we were new enough, right? You've got 3 years post FDA clearance to get the reimbursement. It's called an NTAP, a new technology add-on payment. That's easy, right? 3 years, you got to do it in that time period. The second thing is you have to show a financial model. Again, that's reasonably easy. It's work. But then the third thing is you have to show substantial clinical improvement. And for software, when you're going through the FDA, you don't have to show patient outcome improvement. You have to show improvement relative to the ground truth. In our case, it was relative to neuroradiology and the time to alert of the radiology. We didn't have to follow these patients for 6 months or 3 years. And so we didn't have that data, although as people were using our technology, that data was coming out. And so we really had to scramble to get people to start publishing on this data in order to demonstrate the outcome improvements. We had to work with professional bodies to write letters to senators and congressmen. And we had to engage with the Hill. And it was a process that was totally new to me. Luckily, we were supported. Brooke Byers over there introduced me to someone called Paul Radinsky, who he described as the CMS whisperer, who helped me. He's a physician, actually, who's become a lawyer, but he helped us navigate the ins and outs of how CMS works, a different policy. Okay. And we were lucky to get it.
Yeah. Okay. So is that your whole business model today, reimbursement? I think you introduced kind of a new way, a new business model. You share kind of how the business model works, how you actually get paid.
Yeah. So the reimbursement was really helpful. It was about $1,040 every time our software is used. If certain criteria are met, right? If the patient's an inpatient, financial criteria, I won't bore you with. And that was great. But the $1,000 for the hospital paled into insignificance compared to that switch from medical to surgical DRG. And then as we started to get more and more data, we saw that we were able to reduce length of stay very significantly. So we reduced length of stay in the ICU by between 2 and 3 days, and overall length of stay by around 5 days. And that's real dollar savings, right? $10,000 every time you spend a day in the ICU, maybe $5,000 for a stroke patient on the ward. And so you started to be able to build this financial model. with the reimbursement as a nice icing on top, but it had to be everything else together in order to really get the adoption we got.
Yeah, yeah. So you had to prove that you're going to actually help the hospital make money by identifying these things to kind of get in there.
Yeah.
Yeah, yeah. Okay, so I'm going to switch gears a little bit because in software and in AI, you know, kind of on the cover of every newspaper and magazine, there's all these questions around the safety of AI, whether it's a large language model and the input data, whether you are, in your case, giving advice, if you will, decision support to clinicians. How do you all think about privacy, safety, security in your software?
Yeah, you have to take it extremely seriously, right? So you take it extremely seriously right from the time when you're building your first algorithm. So it's not just privacy and security, but it's also avoiding bias, like having a diverse data set, so that your software is going to do the same thing no matter color of skin or socioeconomic status of the patient. And luckily, the FDA cares about that. So you will not get an algorithm through unless you're presenting data on that. And then, you know, you have HIPAA. You have a very stringent IT security process for every hospital system. And what happens, like the reality of it is what happens is you hire people who've done this before in similar adjacent industries. So like, for example, the radiology space. So we hired people from Philips and from Siemens who knew what they were doing there. You know, our quality management system, we were helped building that up by a guy called Robert Taylor, who's the CEO of Terra Recon. So you build these things based on other people's expertise rather than building it from scratch. And you make sure in your engineers that security and privacy is in their DNA. My co-founder was an Israeli who's at Stanford from one of the elite intelligence services. And for him, security was really in his DNA as well. So that was quite easy for us. But it's something that you have to ingrain into the DNA of the entire company. And the way you do that is through values, right? And our number one value is patients first. But our number two value is quality squared. And that means do a good quality job with what you're doing, but also respect the rules, play by the rules, the quality management system, the FDA, and everything associated with that. And make sure that what you're doing falls well within what the rules are.
Yeah. You were talking earlier, like these challenges as the company grows, you kind of, as the CEO, you face new challenges. One of them is, you know, as a physician, you take a Hippocratic oath, but engineers don't do that, right? How do you kind of uphold those ethical standards with your larger team?
I think it's values. I think you say your values and you live by them. You know, the mission can't be BS. The values can't be BS. The way we wrote down our mission and values was one day, David, my co-founder, and I were like, hey, we should probably write these down. And within about 10 minutes, we'd written the mission and the values. It's so obvious. And the only one was like, how do you word the high quality and multiple different, I mean, quality squared. Hey, he was a stat guy. So that's really the way you do it. And you talk about it every all hand, you talk about it all the time. And you hire people who share those values, and people are attracted to our company because it's helping patients, because it's interesting technology in a regulated space that has some complexities to it. There's many other companies they could go to if they weren't attracted to that.
Yeah. Okay. So thank you. And I think it's so critical for organizations to really think about their values, but then live those values. And I've seen you throughout the day answering questions with such humility, you know, with such a level of kind of growth mindset and introspection. So it's one thing to kind of publish those values, and most organizations do, and to talk about them in all hands meetings. But how do you actually, what are the things that you do to kind of systematize that inside of your organization?
I mean, live by them yourself, talk about them. And then I think funny answer, but you kind of do things to create love in the company. A kind of quirky answer from a neurosurgeon, maybe. But, you know, if you really enjoy working with your colleagues on what you do, then all of the hard, I said to some of the fellows, like running a startup's like eating glass every day, and it can feel like that. But if you love what you do and you love working with the people around you, then it's really easy to pick up the phone and talk about, a problem that you're facing. And what's happened so many times is someone's been on an edge case of should they do this, should they do that? And they'll give me a call, or they'll give my co-founder a call, they'll give someone else a call, and they'll get the answer, which is in fitting with our company's DNA. So I think you got to live it, and through that, it comes out throughout the company and the team.
It's like a level of vulnerability about like who you are and where you're going.
Yeah.
You had some really impressive early investors. Could you kind of share how you told the story to investors and how you captured investors' hearts for Viz.ai?
Yeah, I've been very lucky with my investors. So the very first investment was from Google's Eric Schmidt. He was a professor in the business school. I think he still teaches over there. And he liked it before we even started the company officially. And he liked it because he liked me and my co-founder. He liked deep learning. He liked healthcare, wanted to have impact in the world. And we had a PowerPoint deck, and that was it, right? So I think we were lucky there, really. Right place, right time. Then we were able to pull in Brooke's son, Chad, who was a seed investor from Sousa Ventures. And I think he did it because, again, he liked the space, liked the technology, and like me. And then he sat me down in a dinner next to a guy called Mamoon Hamid, who's the managing partner of Kleiner Perkins, and then Blake Byers, Brooke's other son. I'm here because of Brooke, basically. And we sat there, and I just told my story, and they liked it. And of course, they liked the quality of the team, but again, they fell in love with the idea of helping patients through what they could do. And they did our Series A. And that was just after we got FDA clearance. We had no revenue. We were able to very easily connect them to those doctors in Chattanooga, in Atlanta, who told the real story. And they're like, yes, okay, we should do this. From there, each round it changes, but it really starts to become more and more about the numbers. So Series B, we got it because we were growing fast. Series C, the same. We were growing fast, but not just in stroke. We were expanding to other disease states. We showed we weren't just a one-trick pony. And then Series D is because we showed we were able to tackle multiple total addressable markets. So the provider systems, and then some work we're doing in life science and payers, all of a sudden that we talked about for a while was becoming a reality. And I think for those of you who think you're starting a company, I think it is important, your early investors, because each round is made easier by the person you've gotten before, because their relationships. Like Mamoon's he's probably one of the best software investors out there. He's done things like Figma. He did Box, Slack, and his stamp of approval made it much easier for our Series B, where within a week of going out and pitching, we had 6 term sheets. And so I think really focusing each and every time of getting the best, highest quality investor you can is really worthwhile.
Yeah. Okay, so best advice you've gotten from a VC. You mentioned
Andy. Never listen to a VC's advice. I think VC, someone told me the main skills of a VC is to not give too much advice and not give advice when they shouldn't, know when not to talk. But what they're amazing at is pattern recognition. And Andy Ratcliffe, he's a great investor, but he wasn't one of our investors, he was just a professor, business school class. He told me there's never ever been a successful software company that started out as a platform. It's always been application first. So you do a job for a customer and then you expand from there. So think about Amazon, massive platform. What were they first? They were a book seller online, right? And there's many, many more examples there. And it's kind of that pattern recognition and heuristics that can solve a lot of like time worrying about, should I go left or right? Go, no, this is right. We should be focusing at first on ischemic stroke. Let's get a install base, and from there we can expand.
Okay, great. Worst advice? Anything you skip?
I had advice from an early VC who I've not named, who said, why don't you give this for free to every hospital system and then make money on the data down the road. And I was like, cool, you're going to give me $1 billion? He's like, no, you have to go and sell that up. So that was bad advice. I think you always have to focus on the milestones and stages you're at and tick them off one by one by one. So a lot of you are going to start healthcare companies. So FDA is going to be a key milestone. There's probably no point in thinking about many other things beyond the superficial thought until you progress with that FDA clearance. Because the reality is you will learn how to sell by selling. Right. And you probably won't do all the learning. You'll hire someone in who will help you learn how to sell. And it will be learning. There won't be a playbook. And so there's no point overthinking that sales stage until you've got the FDA clearance. And so that big idea is great for, I don't think it's actually great for the Googles of the world. I think Google, for example, went and really nailed an application and a great business model, which is what allowed them the rights to sort of have really big visions around what they've done in healthcare. Although actually they haven't actually delivered anything in healthcare.
Yeah.
Yeah.
Sure. You know, you just brought up something that's so important, and the companies who don't do it, I've seen struggle with this concept of kind of nail it before you scale it.
Yeah.
And, you know, like you nailed it in the stroke space. How are you kind of determining, you said now there are 16 other areas where you've started to move into. How did you pick the second and the third?
Yeah. Think of it, I talked about this earlier, a little bit of a bowling pin type analogy. So we've done with stroke, all we did with stroke back in 2018 was buy the rights to have a conversation with someone else in the hospital that's adjacent to it. So if you think of stroke, okay, that's a neurovascular physician who's treating it, or a neurologist. What else are they treating? Okay, aneurysms, subdurals, hemorrhages, trauma. They're areas we're all in. But stroke is often caused by cardiac disease, right? And so we were able to build something that connected neurologists to cardiologists to do secondary prevention of stroke. And that entry point of cardiology now has allowed us into valve disease and rarer cardiology disease like hypertrophic cardiomyopathy. It's also the same on the administrative side, right? That administrator you build a relationship with cares about other diseases. So we've expanded that way. But each of our diseases has got the same thing in common. There's an effective treatment that most patients aren't getting, and our triage tools can enable them to get that treatment.
And you all are kind of now looked at as a platform inside of these organizations. Are you looking for partners?
Yes.
There are a few that came and talked to you today.
Yeah.
People are really interested. What do you kind of look for in a partner to your organization? How could you benefit them in terms of entree into the hospital, into your accounts?
Yeah, I think all successful companies are good at one thing. And what we're really good at is last mile delivery of the insights from technology like AI into the workflow. I said we're a workflow company. We're good at that. We're the best at that by quite a long way. So if someone's got an algorithm that's really good at detecting pulmonary embolism or AAA or lung cancer, we're very happy to work with them. In fact, we do. So we've got a third-party ecosystem where multiple other AI companies live on the Viz rails to deliver their insights to our clinicians. And we'll go and do that workflow work. And, you know, it's a revenue share that they get. And for them, they love it because they didn't really have an ability to build that sales force and go to market. It's much faster for them. And for us, it allows us to expand our ecosystem. So I think in 5 years' time, or 3 to 7 years' time, we'll have over 100 diseases on Viz. And my bet is that 70 of them are other people's algorithms initiating the detection.
Okay, so there's possibly some of those entrepreneurs here in the audience. What advice would you give them to getting your attention?
What I've shared values, focus on the patient, make sure that the patient benefits there, number one. And number two, make sure there's a business model. We can't sell it without a business model. So make sure someone in the hospital is ideally making money. That's the easiest, or very clearly saving money, and you've got some evidence around that. If you have those two things and you want to work with us, we'd love to talk to you. Awesome. But we're really strong in neurology, cardiology. We're getting our next area is oncology. If you've got something in psoriasis, we can't help that much yet. So it'd also be like, make sure that we're a good fit for you.
Awesome. Any just general advice for if they're, kind of not wanting to partner with you, but want to be out there? Any advice to our community here?
Yeah, I mean, enjoy it. I was saying to a few people, starting a company is hard. It's really fun. It's the funnest thing you can do, but it's really hard. I was really bad at celebrating wins. You know, I'd get congratulated for some round we've done. I was like, what do you mean? I did that 2 months ago. Now I'm dealing with this horrendous problem around whatever it was. To try and enjoy what you're doing, because anything that you're finding stressful today, you will not find stressful in a year's time. Like, it's crazy. The stuff I found stressful last year, easy for me now. And that will be the same for all of you as well. So enjoy it. Embrace naivety. Like, we always used to say, isn't it amazing how naive we were last week? And it was true. But what that was a sign that we were learning fast. Because you're not right. Like, as an entrepreneur, you're not right. The market's right by definition. The reason why your thing doesn't exist yet is because no one's invented it and fit with the market. And so embrace that naivety and really learn around it. Don't be like proud about knowing loads about your field or about how it should work. That's not true. The way it should work is the way it works, right? And you have to go out and learn that. So, you know, people talk about a growth mindset, but really be humble and really go out and embrace that. And yeah, work with good people. Like, at the end of the day, I think there's some amazing, much more successful and senior entrepreneurs and investors here in this room than me. I think what all of them kind of really think back and enjoy are the relationships they have. They're not talking about the amazing, 110% growth in net dollar retention I had in 2021. Like, no one cares about that afterwards. People care about the people that you meet. So really try and work with really good people who are motivated and driven like you, because you will have to put in long hours. I saw Jeff Dean, the famous best engineer in the world from Google, talk recently, and he wasn't a founder of Google, but he used to come in every night after having dinner with his kids at 9 p.m. till 2 a.m. in the morning, right? And his team did exactly the same. And it wasn't a chore for him. He did it because he loved it. And I think we have the same thing at Viz. People love working at Viz. People love putting that hard work in because the people they work with are kind and we're doing something cool.
Awesome. Okay, before we open up to questions, I'm sure there's lots of questions. What, in 10 years from now, what do you want the headline to be about Viz.ai?
Oh, Viz helps patients. Like, honestly, the same thing as it is today, but we just do it more broadly, more effectively, hopefully internationally. We haven't cracked international. We've got 1,500 hospitals in the US and 50 internationally, mostly because of business model. Like, business model has to fund growth. And so we would love, like, one of my dreams is to have, any doctor in a developed world who maybe has got an immigrant background be able to sponsor their home country hospital and have Viz in both, Khartoum and in Stanford, and have that physician like educating and weighing in on cases for that hospital in Sudan so that those patients can benefit. I'd love that to be the case. We'll see.
Love it. Okay. Any questions from the audience, online or in the room? Oh.
Yeah, great talk. I was curious, when it comes to selecting conditions that you want to have on your platform, how important is the acuity and the need or a time in the formula when you're thinking about, you talked about psoriasis not, being an outlier, but is it because of the lack of acuity or not? I'm curious if you could maybe name the top 3 things of the conditions for them to fit into your platform.
Yeah, so stroke was incredibly time sensitive, and we have other things like pulmonary embolism, AAA, aortic dissection on the platform. But actually, most of the 60 are more chronic, like less time sensitive. So think of hypertrophic cardiomyopathy. It doesn't really have a minute by minute time component to it, right? But what it does have is a patient access component. Right? Most patients with HCM don't see an HCM specialist, don't get the test, don't get diagnosed. I think the diagnosis rate, they say 20%, it's more like 8%. And it's night and day what happens to that patient with a specialist versus with a PCP or a general cardiologist. And there are effective and increasingly effective treatments for that disease. So we look for those two things: are single-digit percentage patients with the disease benefiting from an effective treatment.
Hello, my name is Anto. So I'm creating a startup for pathology, especially in image diagnostics with AI. So I'm first time into healthcare. I had two startups before, but one of the challenges that we are facing right now, especially with AI analytics, is data. So as embedding like a booming founder, first time in healthcare, how do you suggest to tackle the problem of data?
Yeah, so the cold start problem, because right now we have no problem with data. We have 2.4 billion images have gone through Viz, but we were there at the beginning. And as a clinician, I was able to call on my hospital back in the UK, and then relationships that I had to get us some initial data. But the thing that really allowed us to build the first algorithm was those innovator sites who saw the problem even more acutely than I did, and were immediately willing to, twist arms to sign research agreements and data agreements so we could build an algorithm that was good enough to get through the FDA. So I think if the unmet need is strong enough, and you find the physicians who are trying to solve, the pathologists who are trying to solve the problem, they will be willing to provide data. Stanford wouldn't help us in any way, right? So we went to Atlanta and Chattanooga in Tennessee, and I encourage you all to get on a plane and go to other places like less Ivory Tower institutions. You go to Ivory Coast might be good, I don't know, but go places where there's a big need, and they don't have 400 Stanford students or companies knocking at their door for data, because here at Stanford, all the physicians have got their own startups and doing XYZ. So you're going to have to go elsewhere, most likely. But once you've got that first bit of data, you can build, and then from there, it kind of cycles. Yeah.
Hello, Dr. Mansi. Thanks for coming and talk to us. I'm a Medtronic and GE Healthcare alum. I'm curious about how you thought about the business model innovation when you're launching the product, and also as you're thinking about going to European market or Asian markets, how would that transfer lessons learned?
Yeah, well, the second one we don't know. I haven't worked that one out. So I think Medtronic and GE have worked out much better than us. And I think you just have to have a real respect for how other health systems work. And what we'll probably do is form partnerships. We have a partnership with Medtronic, for example, in Europe, and GE could be a good partner for us elsewhere. What we did here in the US was we really understood the ROI for that administrator, and that allowed us to make the sales case, the ROI case. And we went with a very simple business model, like software as a service. We were far from the first to do it in healthcare. It wasn't that common, like people would often do a per patient type thing. But for us, we didn't want to limit the patients who were benefiting from our technology. And so we have scaling to pricing. Like if you have more hospitals, bigger hospitals, you pay more. But we wanted to make sure that if our software was in a hospital, any patient who came through the ED would benefit from it. And so we did a simple modular pricing. That's now evolved into enterprise pricing, a bit like Salesforce, where you'll have a price, and if you go from 3 modules to 4 modules, you'll pay a bit more, and then it'll be the same up to 6. So we're still innovating on that, but it is that general SaaS model, which is great, right? Because it's recurring revenue. You don't have to keep on going back and selling. I mean, encouraging them to use it. They just use it, and every time they add a new module, it's net new ARR. So we kind of borrowed it from the tech world.
Hi, Tim Henderson. There's a lot of concern around algorithmic opacity, and other people make an argument that that's not really that important. For example, we don't really know how certain drugs work they've been here for 30 years. We still don't know how they work. So I'm just curious, how important is it to your company to understand why your algorithms are making the suggestions that they do?
It's very important to the FDA, so it has to be very important to us. So you have to explain it to the FDA exactly how it works. What's really important to me is that there's no black box for the doctor, so that we'll never have something where our algorithm said, "Oh, we think it's a stroke," and the doctor just goes and acts. No, the doctor has to look at the images and make their own diagnosis, their own clinical decision, because obviously a diagnosis has got a lot of things attached to that. Like, what will I do next? What should I do with this patient? What's best? And so really what we're doing is detecting disease and alerting the specialist who then makes the decision. And we do that by surfacing the images. So there's no suggestion that the doctors don't know whether it's a stroke or not a stroke. But when we're going to the FDA, you describe very clearly how it's working. It evolves with more and more data, and you build that in your quality management system, and the FDA can come back and look at it. I think it's important, but I think it's as important as it is in the drug world and maybe the device world.
So we have hit time. We have our networking session afterwards. Chris, Mansi, we are so impressed by where Viz.ai has come from, but I personally, spending the day with you, am so impressed by your humility and just your ability to share your story in a way that is relatable and so humbly. And so thank you so much for being here. Thanks for sticking around. If there are questions that we didn't catch, I'm sure you'll be able to come up to Chris afterwards and ask them.
Thank you for having me. Thanks, everyone.
And also, thank you, Michelle. Awesome job. Great job.